One of the most common discussions that we might be having if somebody is wanting to choose hysterectomy to manage the potential issue they're having is whether or not to keep their cervix. We're going to go through all of that, all of the pros and cons of that. And actually, the trends have changed a lot over the years. So let's go through all those pros and cons in this video. Welcome back to the New School OBGYN. My name is Eric Schmidt. I'm a board certified OBGYN minimally invasive gynecologic surgeon. And in this video, we're talking about the cervix of the uterus and whether or not it should be removed at the time of hysterectomy. Part of the uterus is the cervix, which is generally this lower portion, okay? The inside cavity here, and you have your fallopian tubes and ovaries on each side, okay? Vagina down here. This is the uterus, fallopian tubes, ovaries, vagina. Okay, the part of the uterus that is the opening to the vagina is the cervix. We're going to be going over a couple terms here. We're going to be going over what's called a total hysterectomy, and we're going to be going over what's called a subtotal or supracervical. More specifically, okay? The total hysterectomy is when we remove the whole uterus, okay? That includes the cervix. The supracervical or subtotal hysterectomy is when we just remove the uterine corpus or the body part, and we make an incision across the cervix there at the internal cervical os where the opening of the endometrium starts, okay? Quick terminology review. So first off, based on some of the comments that we have received on the channel, I want to make this clear. We are talking about hysterectomy, okay? Meaning that prior to this, as far as me, the discussion I have with my patients, we've already discussed or already have tried all of the options, whether it's medication options, whether it's lesser surgical options. All of these options have been presented, and the patient is choosing hysterectomy because they potentially have a significant life-altering issue, whether that's bleeding, fibroids, pain, that is causing them significant impact in their life, potentially dangerous to their their whole life in some cases. And so what I'm saying is that we're already past that point, okay? Somebody is choosing to have this surgery because of these significant issues. We don't just do hysterectomy for no reason, which I think, unfortunately, some people think when they view and comment on this channel. I always counsel my patients with not a biased view, and they choose how they want to proceed. That is the new school way of doing things, and that's what this channel is all about. All right, let's get back to whether somebody's going to choose a total or a supracervical hysterectomy and things to consider. And some of the biggest things to consider as far as topics would be pelvic supports, sexual function, bladder function, resolution of the issue, whether or not they're going to have to need another potential surgery. All these are big factors when we're deciding whether to do total or supracervical. The trends have actually been a little bit back and forth. Number one, in the beginning of my training 10 years ago, they did start transitioning from doing a lot of supracervicals to doing a lot of totals. And there's a few factors that play into that. But originally it was thought that there was decreased pelvic support if you remove the cervix, potential decreased sexual function if you remove the cervix. Because from a surgical standpoint, when you're doing a total hysterectomy, or a vaginal hysterectomy, because you have to do a total hysterectomy if you're doing it vaginally. You're removing the whole uterus, meaning you've cut open the top of the vagina at this point, and you can remove the uterus that way. If we do a supracervical, we actually have to put get the uterus through an abdominal incision, so likely have to make a potential 0.5 centimeter incision to a potentially 2 to 3 centimeter incision on the abdominal wall. We've now gravitated more doing total with that new information saying that there shouldn't be any significant change in the pelvic prolapse. Someone can definitely and often do have pelvic prolapse, whether they have their cervix and uterus or not. Actually, removing the uterus doesn't prevent that. A lot of the supports of the vagina are along the lateral walls, and including the uterosacral ligaments, which often are preserved even during a total hysterectomy. So it often doesn't change that point. Let's briefly talk about sexual function surrounding hysterectomy. It is thought, and there's definitely reason to think, that preserving the uterus at the top of the vagina improves sexual function or return to sexual activity after the surgery. It definitely does that. But so sexual function to this area, the cervix is very different for each individual. A lot of people may have pain with palpation of or sex hitting the cervix. Maybe it doesn't alter some people, but some people do get pleasure with it, okay? And everyone is different. Studies have shown more recently that even with total hysterectomy, sexual function through scores done by patients have improved. It improves after we take the big issue that's interrupting their life away. And so overall, it shows that yeah, sexual function is improved. However, I don't want to discredit those that do have a lot of pleasure sensation from this area. It's important to know that about yourself. And that's an important part of this discussion that you're going to have with your doctor on whether or not to keep your cervix. And so I understand that everyone is different. I don't just say, okay, the studies show actually taking the cervix, you should be fine. I don't take that stance anymore. What I say is that know yourself, know your body, know if the cervix has a significant positive component to your sexual function. That will help you make this decision a lot easier. Okay, reason to keep the cervix. We just talked about it, sexual function. Okay, we'll abbreviate sexual. So reason to keep the cervix, sexual function, okay? Again, we talked about it. The studies show that there actually is, whether you remove the cervix or not, but someone can return to sexual activity sooner if they keep their cervix. And again, that goes into shorter recovery time. That bigger incision that used to be in the vagina that may take a little longer to heal, it goes to the abdominal. You have a bigger incision probably around your belly button to complete and remove the cervix. So maybe a shorter recovery because of that, potentially 4 weeks or so before resuming sexual activity compared to 6 weeks to 10 weeks with a hysterectomy done, a total hysterectomy done. We'll say decreased risk, potentially, some scenarios. Because in this area down here, there's a few things, blood vessels, ureter, where an experienced surgeon can easily dissect those away, but you do need to do that during a total hysterectomy. Dissect these things, these areas away to remove the cervix completely. And so if you're making the incision up here and doing the hysterectomy there, you may avoid some of those areas which potentially might increase the risk of the surgery. Again, an experienced surgeon, this isn't a big issue, but there are some cases where someone might have stage 4 endometriosis. Their posterior cul-de-sac back behind the uterus is completely stuck with bowel to the back of the cervix. You could choose to keep away from that and just remove the body of the uterus. And so that's another thing someone could do. And one last point is that if someone has prolapse, there is one of the best ways to fix that prolapse is actually to, it's a little more extensive of a fix, but actually put a piece of mesh, tack it on to the cervix, helps pull up that area, and there's a lot of details we don't need to go into about that, but it leaves an area where someone can help suspend the uterus. If they have prolapse or cervix is falling down, they can help to pull it back up by tacking mesh onto the cervix and that's better than doing it to the vagina because the cervix tissue is more dense. And so those are the issues and the argument for keeping the cervix. Reasons to remove the cervix. Okay. Let's just talk about it right away. Don't need future pap smears as long as your recent ones are normal. No pap. This is a minor point, okay? It might mean more significance to some people, but an overall minor point. This is probably the biggest point, and often why people choose to eventually go with removing the cervix, and that is disease progression. Disease progression. Would you abbreviate it? Because we're going to run into our ovaries there. If somebody is choosing to remove their cervix, it's often because there's a significant issue going on, whether that's fibroids, bleeding. Because if somebody chooses to keep their cervix, again, that's part of the uterus, meaning that fibroids, if someone has big fibroids out here, they can certainly grow them in the cervix tissue. That area can still grow in fibroids. And so somebody could still grow fibroids, potentially needing to remove the cervix and perform what's called a trachelectomy in the future, which actually can be a little more difficult of a procedure than to just remove it at that time, because bowel bladder are going to stick to that surgical area, make it potentially a harder dissection later on down the road. Also, another factor is the bleeding. Somebody can have potentially up to 20% chance of still having bleeding from endometrial tissue in their cervix. Now, when we do that transection to perform the supracervical hysterectomy, there's no like perfect delineation area that allows us to do that. And the endometrial tissues can definitely hang out lower in the cervix. And so about 7 to 20% or so, maybe even more, of patients might have spotting or bleeding going forward. And so for some, that's acceptable. For others, this has been such an interrupting thing to their life, that to potentially have a big surgery and not completely fix the issue would be devastating. And so that means more to some than others, but pretty significant issue if you're still having to wear a pad, something like that, because you're still having some intermittent bleeding. Really shouldn't be heavy. I wouldn't expect that, but intermittent bleeding or discharge from that area. And if someone has something like endometriosis or dysmenorrhea or adenomyosis, those can still affect this area. There's a higher chance that they may need that reoperation or that trachelectomy to remove the cervix in the future because they still haven't resolved the issue. This is about, so let's say if someone has a supracervical hysterectomy, not for any particular reason, they have about a 2% chance of something going on that's going to want them to remove their cervix in the future. That increases by 7 if somebody is getting their supracervical hysterectomy because of things like endometriosis or adenomyosis. 7 times higher risk of potentially needing to remove that cervix in the future. Okay. So we talked about a lot in this, and what I'm saying is that this is a discussion. We're always reevaluating our stance on this. Like I said, trends have changed. Studies have given some light to certain areas. However, we don't want to discount if a patient, you want to individualize each scenario. Take into account if somebody says, you know what, I want this, my priority is my sexual function, even if by chance the supracervical would help that because I feel like I get a lot of sensation from that. Talk to your doctor. They should be happy to do the supracervical hysterectomy for you if you have another significant issue for why you need a hysterectomy. So yes, it's an individual discussion with you and your doctor. And again, understand that depending on which option you want, the surgical route might change. For example, if someone wants a supracervical based on these discussions we had, it would likely have to be a laparoscopic or abdominal large cut incision approach. You can't have a vaginal hysterectomy and a supracervical hysterectomy. It's just not the way that works. Vaginal is arguably the least invasive way to do the hysterectomy. And so that could play into the decision factor and should. I hope this all helps clarify this. And if you feel like you're talking to somebody who's not as flexible in their surgery discussion with you, you can always get a second opinion, okay? We want to do what's best for each individual patient. I hope you enjoy this video. Like, subscribe, follow along if you want to hear more about these issues. We'll talk to you guys soon.